So I invite Dr. Somasheila Murthy to deliver her lecture on clinical pathological aspects of corneal dystrophy. Dr. Somasheila.
Very good morning, and thank you very much. Firstly, I would like to thank Deepankar for including me in this course. Pathology has always been one of my very subject that I'm very interested in. Dr. Murthy, the folder is called, the presentation is called Dr. Murthy. And so I also am, of course, very interested in cornea. So putting the two together, I thought I'll discuss 3 cases which are basically corneal dystrophies, but maybe a little bit unusual in their clinical presentation, or maybe usual in the clinical presentation, but this is how pathology really helps us in classifying and differentiating amongst the various corneal dystrophies that we have. So straight away I'm going to jump into the case. The first case which we saw during the COVID times is 37-year-old, and he had undergone LASIK in both the eyes in 2004. He was doing well, he said, for almost 12 years after LASIK. And in 2016, he started developing episodes of recurrent redness and discomfort and so on. And then the vision also started becoming blurry for the past 1 year before he presented to us. So nothing systemic, and he said that he had one sibling but who has no eye complaints. When we examined him first, his visual acuity was improving to 20/30 with some refractive error in both the eyes. And this is a clinical picture in both the eyes. What you can see is this very sort of unusual reticular looking pattern of some kind of deposits which were lying in just around the LASIK flap. I'll show you in the OCT where they were located. The anterior segment OCT very beautifully shows us almost like a in vitro pathology what the patient has. So this is the epithelium, that followed by this hyporeflective areas is a thickened epithelium, and then the LASIK flap follows. And both the anterior surface of the flap as well as within the flap as well as its posterior surface seems to be layered by a hyperreflective material, and that is what the material that we are seeing in the clinical photographs are. So the patient was counseled, and initially he didn't want any surgical therapy. Then subsequently, as the vision dropped, we performed epithelial removal with the help of alcohol, and also PTK, which is phototherapeutic keratectomy, to smoothen the cornea and improve his vision. So I didn't want to sacrifice any of the tissue because it is very important for me to know what dystrophy this patient has, because morphologically it doesn't really resemble either granular or macular or lattice. It could be anything. So when we went ahead for surgery for this patient, in fact, what happened was almost the entire LASIK flap just peeled off very easily when we applied alcohol. So we removed the entire LASIK flap, and this is the histopathological section just of the anteriormost part of the epithelium and stroma. Epithelium is denuded, it's not present in this specimen, most of it, except for here. And this is under low power. When you enlarge it, you can see already that there are some deposits. This is H&E stain, so there are some bluish looking deposits in the subepithelial region, and this is just the flap that is folded upon itself. In high magnification, there are these, this is the hypertrophic epithelium, which is compensating for what the patient has. In some areas it's attenuated, and the epithelial cells, the basal cells, look quite large and a little abnormal. And the subepithelial region, which should ideally be the Bowman's area, is replaced by the presence of these pinkish looking deposits. This is under Mason's trichrome stain. So you have this almost, ideally it should be brick red, but here it's pink, more of pinkish looking deposits. And this is under higher magnification, 40x, you can see the same deposits. So under H&E stain, this is the epithelium again, and then part of the anterior stroma. And when you do Mason's trichrome, this is various, this ballooning is artifactual because we use alcohol and we remove the epithelium. It wasn't truly there in the patient. And you can see these deposits with some even basophilic areas in this. So these orange red deposits with Mason's trichrome is very classical for granular corneal dystrophy. Of course, if you have an entire corneal specimen, this is of another patient, so this is the entire corneal specimen going all the way from epithelium, and then the anterior stroma, this just below the epithelium is the Bowman's. So in my patient, what we had was just this much, just up to the epithelium. And this is the entire stroma where you have all of these very amorphous looking deposits. And when you do Mason's trichrome, this is the almost brick red color that you see for these deposits. So we had clinical diagnosis. We suspected, clinical we didn't have a diagnosis. We were suspecting dystrophy. Pathology helped us, telling us very strongly that it is nothing but granular dystrophy. Now we needed genetics, the genetical classification of the patient, so that we could finally confirm the diagnosis of a corneal dystrophy. However, this patient declined to undergo genetic testing, so that part is remaining. But I think that with 1 and 2, it's pretty obvious what diagnosis the patient has. This is post-therapy in both the patients, in both the eyes, showing very clear corneas. And so far he's not, so this was in 2022. So far he has not had a recurrence of the dystrophy. Very recently when I corresponded, he said that his sister, who's not undergone any LASIK, but now she's almost in her 40s, is also presenting with blurring of vision, so we've asked them to come for follow-up. So these are both the eyes. So that was the first case. The second case is more classical what you have. So the second patient came to us without any previous surgery, but had decreased vision in both the eyes. What we can see are these very discrete whitish deposits which are in the anterior and mid stroma in this patient with clear intervening areas. So this is almost clinically, the phenotype is classical for granular corneal dystrophy. We don't really need to worry about whether it could be a different kind of a dystrophy. So this is the AIOC2024, which shows that most of the deposits are located just below in the anterior stromal areas. There are some deeper deposits, but they become less dense. So this patient also, we took the epithelium, they debrided it with the help of alcohol and applied phototherapeutic keratectomy to the anterior stroma to improve the vision, and subject to histopathology. So just for the sake of the two audience who are here, and Dr. JB obviously knows, that in the pathology department, so it is good to take that specimen. What we do is, because the department is right in-house, so we just put it in a small Eppendorf tube, and that tube has formalin in it. So 10% formalin, empty the tube. Typically it has PBS, so empty that and put this formalin and put the specimen. The other way is to use a filter paper and just orient it on the filter paper, so and then label it, which our pathologists really like, but our fellows don't do that. And then it's processed and then sectioned as usual. So this is the second patient where you see under low power, so all the epithelium has curled up. That is why I was saying to spread it out on filter paper. For the first patient we had done that. And these are the classical deposits which are staining with Mason's trichrome, as I showed in the previous case. This patient, we could perform genetic analysis which showed positivity for the TGBeta1 gene. The last case I'll end up with is another patient who's 45-year-old, and he had recurrent episodes of redness and so on, so recurrent corneal erosions basically. And he didn't go all this time in his life for any checkup, because he didn't know that he has poor vision. He thought this is normal vision for what you should have. He seemed to be managing with his left eye, which was 20/40, and in the right eye he had actually very poor vision. So this is how lattice dystrophy could look like. When you look at it with direct illumination, you can just see centrally the cornea looks very cloudy. Of course, there are peripheral deposits also, not shown in this picture. But when you use retro illumination, then you can see all the lattice-like lines in this pattern that are just lit up in retro, which match the clinical pictures that I showed you here. So this patient we subjected to transplant for the right eye, where his vision was very poor, because this dystrophy involved very deep in the cornea, and we wanted to do DALC, but it got converted to penetrating keratoplasty. This is a button. So in the DALC button, what happens is we insufflate air. So all you see is the air in the stroma. So you know how in DALC, I'm sure Rima wouldn't have wanted to see or bothered to see, but what we do is we inject air, then we dissect out the stroma, then we have to go deeper and so on. So that's why you have sort of in layers. So we dissect out in layers. So you have one layer here with the epithelium and subepithelial region and anterior stroma. So in this layer, we can see the deposits below the epithelium. By now, all of you have become experts at what to look out for. And the lattice dystrophy is amyloid, so we have to use a Congo red stain for amyloid. It stains a little pinkish or red, and this amyloid substance is very well seen. It has apple green birefringence, because it polarizes, and this is what we are trying to show here in this slide. So it's a beautiful sight to see under the microscope when you see this stars in the sky kind of appearance for this dystrophy. So, so again, for this particular patient also, we could have genetic analysis and which matched lattice dystrophy, and it also matched perfectly for the under the new IC3D classification. So that's all I had, and some of the slides are from the new center at Shantilal Sanghvi Eye Institute, where we have cases, and I acknowledge my fellow Dr. Prajakta, who helped me put together this material. Thank you very much.
Thank you, Somasheila. I'm quite impressed with the ASOCT pictures. It's almost looking like histopathology.
Right.
And another point is that, you know that when I was getting training at Doheny Eye Institute, Dr. Narsingh Rao, though some cases like lattice dystrophy was very classic,
Yeah.
he used to ask for a panel of histochemical stain,
Right.
like you do that trichrome, Congo red, and Alcian blue.
Right.
Though they're obvious, it's you know, you can focus it, but sometimes you can have combined lesion,
Yes,
combined dystrophy,
Yeah.
like, you know, granular plus amyloidosis or
Yes.
this. So it will be good practice to do that one, but most of the times clinicians is correct in making a diagnosis.
Yes.
Nowadays,
So,
another important thing is that nowadays for pathologists it's little frustrating to get only small tissues like debridement of the epithelium with a little stroma. It becomes a challenge to the pathologist. But it's a very nice, well documented, simple cases. I wish the PGs would have been there, because the corneal dystrophy is a condition which is often asked in the exams.
that's right.
And it's a beautiful.
Just to do justice to our pathology department, our pathologists, they always do all the stains. I just picked up the ones. So in these
They do
cases,
all the
nothing. Yeah, none of the other stains had any deposits. So
Yeah.
they don't believe us. They do it on their own. So
Yeah. So when I was doing the pathology more intensely, there was no ASOCT.
Right.
Now with the ASOCT, the pathologists have got can narrow down his diagnosis. Histopathology. It might be very helpful.
right. Thank you.
So I think you should do ASOCT in all corneal
Right.
dystrophy.
Yeah. Thank you.
Thank you. Very nice presentation.